Good evening, everyone. Welcome to the weekly webinars presented by Yashoda Hospitals. Today, it gives me an immense pleasure to invite Dr. Sai Kiran Reddy, who is going to speak on Polytrauma Approach and Updates. And before he speaks, let me give a short intro of Dr. Sai Kiran Reddy. He has great experience in emergency medicine. Basically, he holds an MD emergency medicine degree, and after that he has done a lot of publications in the field of emergency medicine, and he has worked in wide variety of linguistic spectrum where he has seen different areas of emergency medicine. And currently he is working as head of the department at Yashoda Hospitals Malakpet emergency department, where he is also program director for CCTEM and lead for DNB emergency medicine. And without wasting much time, I would like to call Dr. Sai Kiran Reddy to initiate his session. Thank you.
Good evening, all. Thank you so much. Thank you, Dr. Panik sir. Good evening, all. So today my program, my talk on polytrauma. The main reason for opting this topic, I would like to say the major leading causes of death in India would be a traumatic, which is an avoidable cause, which is a preventable cause, which needs to be addressed in a methodical way. And we have to go forward in approach by following the international guidelines. So all of my presentation things would be from the recent updates from ATLS and recent edition. Thank you. So today's outline on the topic, the factors, the newer trend, the initial assessment, any change in the approach, the criteria for the referral at the primary setup, that is before the hospital or at the scene, the communication tools that are used in communicating to the trauma center, tertiary centers, the primary survey, how to do it, and simultaneous preparation for the treatment. Any special situations you need to think after the primary survey, the secondary survey, and imaging modalities, the definitive time-sensitive organ-specific injuries. We have to be more precise on this, and the final breakout to the family. So the newer trends are the factors that are applicable here, the time, practical applicability, and the medical advances. At whatever the center you reach, you have to know whether these three, you have to make your own decisions. So we have to treat the greatest threat to life first. So never allow the definitive diagnosis to impede the applications. And then the detailed history is not essential to begin. So you have to have a brief history, take your own time, but evaluate whether this practical applicability at the center where you are is appropriate right for the time. So the following thing says that you have to have the total assessment in following steps. Primary survey. What are the adjuncts that you are concerned in the primary survey? How do you re-evaluate? How do you proceed for the secondary survey after the re-evaluation? Then what are the determination to need to transfer and plan for the definitive care? So the next couple of slides would show us what are the national guidelines for doing a field triage for injured patients, which are categorized into red area, yellow area. These are the following patterns. Among them, some we always consider dangerous mechanism of injury, multiple trauma, that is polytrauma, involvement of multiple organs, long bone injuries, and any other evaluatory points like unstable patients, unable to communicate, having altered vital signs, and age, extremes of age at less than 10 years or more than 65 years with the altered vital signs. All this come under a red category criteria. Seeing the yellow criteria, you have the different mechanism of injuries of high risk auto crash. There is more than 12 inches, more than 18 inches at site. Then need for extrication from the entrapment, death in the passenger compartment, vehicle telemetry data consistent with severe injury, the pedestrian or bicycle rider thrown or run over, fall from height more than 10 feet for all the ages. Then EMS judgment, yes, any pregnant ladies, the special point what I want to emphasize here is pregnancy more than 20 weeks, anticoagulant use, suspicion of child abuse. If concerned, please definitely refer the patient or take the patient to the trauma center. These two categories, what we have discussed, is for pre-hospital judgments and making the calls what to do for the next. Coming a small techniques for handover, missed handover techniques, the mechanism of injury, medical complaints, and I stands for injuries or information related to the complaint. S stands for signs and symptoms. T stands for the treatment given and the trends noted during the transit or during the transport to the hospitals. The next is the primary survey with S bar communication tool. In the S bar communication tool, you definitely have XABCDE, the main primary survey that needs to be assessed. Then going to the backgrounds, you have to go for the ample history, what all medications have been administered or the patient is on, what all images has been taken, any splints or reduction techniques that have been performed there, pre-hospital. Then coming to the A, current assess status, we have to evaluate for physiology, response to interventions and the likely injuries. Coming to the recommendations, you have to have the transportation mode and capability of the transportation. Then what are the transport interventions that may be required and other necessary interventions that are required. So these two are missed and S bar are the handover techniques that we follow. Then if the patient is a single person, the victim is a single person, then we follow ATLS in the daily situations, primary survey, secondary survey, diagnostic studies, and plan for the definitive care. If it is multiple, then you have to have a, prior to this primary survey, you have to have a field triage that is happening in the outside the hospital. Then coming to the primary survey in detail, previous guidelines used to say A, B, C, D, E, but now they have re-emphasized to add X factor before the addressing the airway. That is exsanguinating or external hemorrhages. That means massive bleeding from the open extremities or the wounds to preserve the circulatory volume. Along with the assessment of ABCDE, you have to first concentrate on the immediate extraneous external hemorrhages. And the remaining airway, breathing, circulation, disability, and exposure and environment would definitely tell you what are the other things that you need to look out. Because some you have to stabilize one by one at a step manner. But always keep that hemorrhage control, restoration of the maintenance of end organ perfusion or the criticality here. Disability doesn't say only of metabolic disability, it is physical disability here, not like a medical case. It's in the injury to the central nervous system like traumatic brain injury or the spinal cord injury. Exposure is definitely necessary irrespective of the age, irrespective of the gender. We have to have complete exposure and seeing for missed injuries while maintaining the patient's dignity and privacy. So we have the log roll techniques for this. So the next thing are why the X factor has been identified here is for potential areas to identify the bleeding, the closed spaces and the external things where there are high chances of losing major volume of blood. Because we are thinking that all the closed compartments of the body like intracranial, intrathoracic, intra-abdominal, We are forgetting about the long bones. We are forgetting about the retroperitoneal space. We are forgetting about the external loss from the open wounds of the limbs where all the injury has happened. These are the potential areas. Then to prevent, you have to first initially have the compression techniques. The first compression should be 3 centimeters or 2 inches apart from the primary wound. This is a technique. And if this also doesn't stop, you can have a one more compression proximal to the first compression technique. But you have to have a time limit, watchfulness on how much time you need to apply for this compressions, because regularly you have to release, emphasize that the limb distal to the compressible hemorrhage or the compression should not go for ischemic injuries. Coming to the airway maneuvers, we generally follow head tilt, chin lift, but in trauma, to prevent the cervical spine injury, we are following jaw thrust maneuvers. We have to clear the secretion, supplement the adequate oxygen, putting the target of normal respiratory rate and oxygen saturations. Intervene in the definitive airway when and wherever it is required. If you have felt the difficult or the failed airway, you follow the advanced airway protocols with a video laryngoscopy. Still you are not unable to do it, you definitely prefer for the surgical airway like cricothyrotomy or the jet ventilation techniques. Airway protection, people always think that airway should be protected only because of the threatened airway. No, there are the other things where you have to think, anticipate early cardiac arrest and early anticipate early to protect the airway, like the severe chest injury with respiratory failures, significant hypoxemia or hypoxia or hypercapnia, having hypoventilation due to neurological or respiratory failure. You have altered mental status due to shock. You have a disability with GCS of less than 8. Then high percentage of body surface area of burns. Because in trauma, everyone thinks that we have been injured because of the trauma. But apart from the trauma, what are the other factors that are influencing the person, influencing the physiology of the body? That means prolonged exposure to cold, prolonged exposure to heat. So the secondary injuries that have happened because of this multiple other external environmental factors, we definitely need to consider the treatment modalities what we are planning here. Then coming to the cervical spine, because along with the airway, the cervical spine, which is the most important for the conduction of the neurological cord bundle through the cervical spine through towards the lumbar spine, for throughout the body, we have to think of Canadian C-spine rule, where dangerous mechanisms and nexus criteria. If you are meeting one of them, you have to plan for the imaging techniques for the cervical spine. Coming from breathing and ventilation, you have to look, listen, and feel. You have to inspect bilaterally, see for the rate, rhythm, pattern, and paradoxical breathing patterns. Listen for any air, decreased air entry bilaterally. Feel for the trachea, tenderness, and the chest compression tests. These are the differentiating factors where if you have a pulmonary contusions, simple hemo or pneumothorax, tension hemo or pneumothorax, what are the things you identify variously? We have to look for the breath sounds, tracheal position, neck veins, blood pressures, and then you have to plan accordingly. If you have uh, tension pneumothorax, you have to do a needle decompression where the technique has changed from the second intercostal space towards the fifth intercostal space in the anterior-axillary line, the same place where you are planning for the intercostal drainage. For massive hemothorax, you have to plan for the immediate intercostal drainage because these are the obstructive causes of shock. Flail chest, you anticipate for more degree of lung injury and anticipate more injuries in the coming time. you have to plan for immediate intercostal drainages. The diaphragmatic injuries and tracheobronchial tree injuries, you have to notify for the pneumomediastinum or diaphragmatic herniations post-trauma. So we have addressed airway and breathing. Now we are seeing for circulations as we have discussed. The major places of bleeding or the loss of blood is abdomen, chest, pelvis, and any extraneous outside hemorrhages, retroperitoneum, floor, and muscular and subcutaneous plane. Then the long bone fractures. You have to perform an EFAST where you are checking for both sliding sign and seashore sign in the lungs with all the four quadrants: subcostal, that is subxiphoid, then Morrison's pouch on left splenorenal and around the bladder. So any positive EFAST should always be done with a CT contrast to see for the active leak and plan for emergency laparotomy. Because the most commonest areas we lose is retroperitoneum, floor, and the fracture sites that are long bones, because we generally don't think that these are noticed unexamined in the primary setups, but coming to the tertiary setups, we definitely notice that. Then coming to approach for shock, you have to think of obstructive because immediately it can be reversed. Then distributive, that is spinal shock, that is neurogenic shock, and any immediate reversible things are cardiogenic, cardiac tamponade, and coming to additional sepsis and soft tissue injuries or any anaphylaxis during the treatment or any cardiac contusions or traumatic brain injury itself is inducing the circulatory compromise because of the raised ICT. But here we have to think that any active intra-abdominal bleed should be treated with permissive hypotension, and you have to activate for massive transfusion protocols. But always think that blood is the replacement for blood. Never think that the crystalloids, colloids, or the inotropes would serve the purpose, because in trauma, the last thing is blood. So definitely we require the blood. Disability, you check for pupils, whether they are equal, unequal, pinpoint, dilated, non-responding. You have to make the calls. Then apart from that, AVPU score is at outside, but after arrival, you have to see for the GCS, where the GCS of less than 8 would be an indication to secure the airway, and movement of the extremities and the rectal tone, because rectal tone is lost, then the cord injury is high likely to be a grievous injury, non-reversible injury, where you would require a CT polytrauma with a MRI spinal cord. Then apart from that, exposure, seeing that you have to protect the dignity of the patient, you have to undress the patient, remove, see externally completely, take the help of the multiple people, see that the person is properly stabilized with manual inline stabilization or the stabilization of cervical spine, see completely over the back for any external injuries, midline tenderness, midline deformities, and any external things that you feel which are abnormal. Coming after the primary survey or during the primary survey, you have to parallelly prepare for the urgence of the primary survey. That would include checking of the vital signs, doing a fast examination, securing the IV canalizations, securing all the tubes like Wright's tube, pulse ox, Foley's catheterizations. But Wright's tube we don't prefer in head injuries because we don't know the status of the base of the skull fractures, so we will not prefer. So urinary tubes, gastric tubes, you have to perform a chest x-ray, do a chest compression test, do a pelvic compression test, immobilize the pelvis if pelvic compression is positive, get an ECG, then prepare for the secondary survey. But before going into the secondary survey, one point I would like to make more important here is the special population and the situations, because the regular adult would throw you with all the abnormal vital signs, but these are the categories which will not show any abnormal vitals or abnormal things. They are child, pregnant women, obese, people who are obese, and people who are elderly, because their response or the contracting mechanisms are very slow in them. And associated burns, dehydration, duration of exposure to the environment, then extrication scenario and time. The dangerous unknown mechanism, never back down to document. That is my only message on this slide, to say that don't back down to document the mechanism, because always that is a leading scenario where we would lead for the investigations. 3 C's of communications again. Cite the names clearly because it's a team effort. Clarify the instructions, closed loop communication. Check whether they are responding, they have heard or not. Then you have to make your calls. Going to the secondary survey from head to toe examination. Again, reassess with the chest compression test, pelvic compression test, any bony injuries, long bone injuries, soft tissue injuries, the compartment syndrome at the limbs, then vascular injuries, pulses, peripheral pulses, and peripheral mobility, and any soft tissue injuries. Then assess for the nerve injuries. Then go for the spinal cord injuries. After your secondary survey, the calls would be 2 large bore IV canalizations, get a arterial blood gas analysis, interpret the E-fast, and get a 2D echo and ECG, and plan for a CT polytrauma and X-ray of the extremities, which all you are suspecting a injuries. Choosing ultrasound versus CT, I would definitely recommend, and the ATL is also recommends better to choose a CT polytrauma with IV contrast, irrespective of the scenario of the patient. Even if the patient is vitally stable, there are some minimal uh, or major injuries on the retroperitoneum which are missed out, and major surgical profiles reserve the blood and plan for definitive care after your investigations. The treatment modalities would be IV fluids, antacids, antiemetics, antibiotics, analgesics, procoagulants, blood and blood products, tetanus prophylaxis, splinting appropriately, prevent the secondary injuries, and the comorbidities. That means organ-specific treatments like anti-edema, steroids, anti-epileptics, limb positioning and elevation. So you have to think all organs as a coordinating unit, because thinking about a single organ where you have identified which is visible outside would not only be the only organ that is injured. So always prevention of the secondary injuries is in our hands and our techniques to follow and to prevent them. So these are the indications for the CT scan of head with GCS of less than 15, age more than 60 years, age more than 65 years, then considering CT with loss of consciousness or without loss of consciousness, you have multiple indications where you have raised ICT features or altered intoxications or memory loss of memory, any focal neurological deficits, any fall down of grievous mechanisms. You would definitely prefer for imaging techniques. To emphasize here, I would like to make a point on the types of intracranial injuries for trauma. Regularly, there would be a most commonest things are SDH, SAH, EDH. But apart from that, the major concerning factor for the emergency physicians are the herniations, the transcalvarial herniations, subphalangeal herniations, transtentorial herniations, uncal herniations, and tonsillar herniations. Because these are the things that would decide the factor how fast we need to act to go for the decompressions. Because apart from the regular volumes that are collected here, being a EDH, SDH, and localized contusions and the midline shifts, you also have to think about this kind of herniations where there is a high possibility for poor recovery. Then coming to indications of surgery, any large volumes of more than 25 ml, evacuation is needed. Any posterior cranial fossas with an SDH of more than 10 mm thickness and more than 5 mm of midline shift, any SDH of with the decline of GCS within 2 points associated with asymmetrical or non-reactive pupils, or any acute EDH of more than 25 ml with more than 15 mm thickness, or associated with more than 5 mm of midline shift, or a GCS of less than 8. Any cerebral contusions associated with GCS of less than 8 and midline shift of more than 5 mm or herniation. Any cerebellar hemorrhages more than 3 centimeters in diameter or resulting in mass effects with brainstem compression or hydrocephalus. These are the scenarios where you would be thinking on to take for decompressive craniotomy. Coming to the spinal cord injuries, you have central cord syndrome, Brown-Sequard syndrome, the direct injury, compression effects. Not always the injuries that would speak out. There would be a contusion, there would be a vascular edema, vasogenic edema around the spinal cord that would result for any uh, neurological status. That would be most commonest would be tetraplegia. Complete paraplegia is for 25%. Complete tetraplegia is 20%. Incomplete paraplegia is of 19%. Apart from that, the closed spaces where you would be thinking is the pelvis. Because the pelvic floor, which is a closed space and the major highly vascularized bone, you have to think of what kind of fractures the pelvis has undergone, whether it is a vertical shear compression, lateral compression, or other compression fractures with disruption of the symphysis pubis and disruption of the posterior pubic symphysis and ischio joints, what all are there in the posterior aspect also. Apart from this, we have to think of vascular injuries. These are the hard signs and soft signs. Whenever you are checking for peripheries, you have to check for pulsatile bleeding, expanding hematoma, pulselessness, acute ischemia, or the vascular thrill, the bruit, or persistent hypotension. Because these are the things that would suspect for the immediate clamping and evaluation for the distal to the tissue, wherever you are thinking. Coming to the treatment, you have an additional point here. You have to think of tranexamic acid. This is the mechanism where it binds to the plasminogen, creating an activated plasmin, where you have it blocks it by binding fibrin and inhibit the fibrinolysis. So your administration of tranexamic acid is definitely recommended in case of trauma. The previously they used to recommend 1:1:1 on the replacement of the hemorrhagic shock. But now it has been redefined that initial 2 or 3 packed cells should be immediately transfused whenever you have a documented or a evident hemorrhagic shock. Along with them, you assess the tegrotem for viscoelastic testing to rapidly guide for targeted blood products and calcium replacements. Then again, coming after your evaluation and identification of the things, you have to have the communication tools to organize your thoughts, prepare for the meeting, meet with the family, debrief them with the family, think that you all are one team, involve all the neurosurgeon, trauma surgeons, the orthopedicians, the general surgeons, and you also be a critical care team and ensure the family that we would try our best to get back the patient to the normalization. So my take home message for today, by this I would end my topic. Always team efforts are important. Follow the systems. Think of uncommon in common presentations. Treat appropriately. Please follow the methodical approach, multi-departmental approaches, and counsel and convey to the patients as a team. So definitely follow these things. Never be too early to interpret or too late to make the call. That is my take home message. So, any questions?
Thank you, Dr. Sai Kiran Reddy. It was a great presentation, and you have elaborately told about the management of trauma patients, and along with that, you have also detailed the small things which we do in emergency medicine on a daily basis. Mainly, I would like to appreciate the thing which you have specifically mentioned, like detailed history is not a mandatory thing before you go to closer to the patient. Even the shortest history and without history, also these trauma patients need to be approached and initially stabilized. And also the national guidelines for the field triage, which you have mentioned, were very excellent. And missed handover technique, I seriously urge all of my fellow emergency physicians to follow this. And you have also thrown some light on change in ABCDE management to XABCDE. That was also a great input. And change in pneumothorax. In case of pneumothorax, how to do needle compression. That is also a good that you have told, so that most of our emergency physicians are staying updated about this. And change in the massive transfusion protocol, which you have told. And I specifically like the way how you have told that we have to counsel the patients as a team, not as an individual person. It was a great lecture. Thanks for your time. We'll open the floor for questions for next 2 minutes. If there are no questions, we'll close. Thank you.
Thank you, sir.
Because we have time, I would like to ask a simple question to you.
Yes, sir.
What you give a advice to the upcoming emergency physicians who are enthusiastic about emergency medicine? What suggestion or what advice you will give based on your wide clinical practice which you or experience you have? How to, like, in case of trauma patients, what is the important thing to keep in mind while handling these patients?
Uh, See, in my vast experience, what all I have gained till date, I would definitely say that emergency physicians are the multitasking leaders that are progressing in today's world. So what I say is we are capable of taking multiple decisions at a time, coordinating multiple people as a team. So trauma, majorly what we see is people are afraid to handle those things because of two things. One person may be afraid of the blood, one person may be afraid of the scenario, or one person may be afraid of the situation or the aggressive attenders that are accompanying present today's life in the emergency departments. So being calm, following the methods, taking your decisions one step at a time without wasting the resources, and making a proper plan and going forward and conveying it strongly to all the team members, and conveying strongly to the attenders, and conveying strongly that I definitely want this. I know that these are the complications that are going to happen for them, for this patient, but you have to accept them and take the challenge, go forward enthusiastically, achieve something so that you can say that your efforts have made someone's life or someone's family a big difference. So that motto would always keep all of us as an emergency physicians to drive forward and put the complete efforts from our side.
Thank you, Dr. Sai. You have clearly mentioned that don't be scared to go closer to these patients, and definitely as an emergency physicians, we are going to make difference to these patients. So once again, thanks for your valuable time, and thanks for your great inputs in this topic. And once again, we'll meet in the next week with the new upcoming topic. Thank you all.
Yes, thank you so much for Yashoda Hospitals, from the management, for giving us this opportunity and going forward. Thank you, sir.
Thank you.